Hello and welcome to this Video Hemop podcast. In this episode, we explore the latest advances in haemopoietic stem cell transplantation from the EBMT 2026 annual meeting, from innovations in the management of graft-versus-host disease and evolving transplant strategies to new insights into donor selection and the growing role of measurable residual disease. The field continues to rapidly evolve. We will hear from leading experts on how these developments are shaping clinical practice and improving outcomes for patients undergoing transplantation. So let's begin. Graft versus host disease remains a major challenge following allogeneic transplantation, particularly in steroid-refractory disease. Mohamed Moti discusses key advances in both acute and chronic GvHD, including a novel microbiome-based therapy for severe gastrointestinal acute GvHD, as well as the expanding role of targeted agents in chronic disease.
We're here at the EBMT 2026 annual meeting in this beautiful city of Madrid. And as you may guess, GvHD has been key and very important topic in this meeting. And the good news is that we have a lot of new data, lots of novelties, whether it's about acute GvHD or chronic GvHD. When it comes to acute GvHD, I think the biggest highlight is the presentation from the Presidential Symposium by Professor Marar and colleagues about the role of microbiota, especially the drug called now Xervitag or MAT13 previously, in a steroid refractory, but also ruxolitinib refractory acute GvHD patient with GI involvement. We know very well this is a population with a highly unmet need. We do not have any effective treatment in this setting until recently. We would usually use the so-called best available therapies, but usually they are very disappointing. And here in this pivotal so-called ARIS trial, the investigators included 66 patients with severe GI acute GvHD. These are patients who received and failed corticosteroids, high-dose corticosteroid, but also ruxolitinib. And the good news is that using this microbiotherapy with MAT13, which is an enema, it's a pooled multi-donor preparation, which is scaled and transformed into drug, actually allows you to achieve more than 60% response, made almost majority of complete responses, but also VGPR, very good partial responses. And these responses, especially the CRs, are sustained in time because what we observe at day 28 is going to be sustained at day 56. And at the end of the day, this will translate into an overall survival advantage with more than 50% at 1 year. This is clearly transformative, and this is clearly bringing a new effective and safe treatment for those patients who until recently didn't have many solutions. And hopefully we will be able to use this microbiotherapy on a larger scale in the near future. When it comes to chronic GvHD, we have also lots of innovations. In the last 10 years, we've seen the approval and advent of ibrutinib in the United States. Ruxolitinib is approved and available almost everywhere, and it is proving to be a great drug for instance, steroid refractory chronic GvHD. More recently, we have seen the approval in the United States and in many countries across the globe of the ROCK2 inhibitor, namely belumosudil. And this ROCK2 inhibitor, belumosudil, is proving to be highly effective in those patients who are refractory to corticosteroids, but also who are refractory to ruxolitinib. So this is bringing really an important, effective, but also easy to use, safe treatment oral drug to this population. We know very well that chronic GvHD patients are really suffering from physical disability. They have an altered quality of life, and at the end of the day, they will have a dismal outcome. So the advent of belimozidil in this population is very welcome. We should not also forget, although this is not yet available in Europe, about axatilimab, which is approved in North America. And again, this is a very specific IV monoclonal antibody which works very well against the fibrotic process involved in chronic GvHD. So in summary, you see things are moving forward in the right direction positively when it comes to acute, but also chronic GvHD. And I believe these are really good news for patients and for all of us involved in the field.
Together, these developments highlight meaningful progress across the GvHD spectrum, offering new options for patients with limited treatment choices. Beyond post-transplant complications, attention is also turning to donor-related factors that may influence outcomes. Carmelo Gunari discusses the role of germline predisposition in donor-derived leukemias, which, although rare, may account for a significant proportion of these cases due to inherited mutations passed through the graft.
The presence of germline predisposition is important because sometimes what happened in the past when we didn't know that these germline mutation might be present, or we were not able to identify them because of the limits of molecular tools in the past decades, we were witnessing a particular case of leukemia or relapse after transplant, which is called donor cell leukemias. This is only 2 to 5% of all relapse after allogenic transplant, but about 80% of the time, this is probably due by the presence of a germline mutation that inadvertently is passed along with the graft. Now that we are able to identify this mutation, we know that the majority are those genes that perhaps have not extra hematological phenotypes and therefore are difficult to identify in donors if you don't know anything about the family history of the donor or you didn't identify this with the molecular tools. Therefore, we, together with the Chronic Malignancy Working Party of the EBMT, in one of the efforts of the harmonization guidelines, try to tackle this problem. After a meeting in Berlin where we gathered together, we decided to address what we can do for the best clinical management of donor cell leukemias. And these guidelines are soon to be published in the Lancet Hematology. And today we have the session where we will discuss how to best diagnose and approach this patient. It's imperative when we have a donor cell leukemia to assess the molecular profile of this patient, because sometimes not only is it important to understand if there's a germline predisposition and therefore go back to the donor, if it's a relative, or especially if it's like an unrelated donor, to understand if we can reach out to the donor himself or herself. But also to understand if there are molecular targets that we can use for the donor cell leukemia that we have in front of us, and perhaps bridge the patient to another second allogenic transplant, which in most of the case is the only curative option for these patients. But it's obviously tricky because these patients are already being allografted, and therefore a second allograft is decided upon a specific indication like age, the performance status of the patient, the previous iatrogenic burden and chemotherapy exposure. So a lot of factors goes into that decision.
Building on this, advances in genomic profiling are improving how these risks are identified in clinical practice.
So germline leukemias are entities that have been recognized in the recent 10 years, in the recent decade, thanks to the application of the new molecular tools and the discovery of numerous gene mutations which are germane to the disease pathobiology, in particular of MDS and AML. In general, in all comers MDS and AML, 5 to 10% are individuals who carry or might carry germline trait. And this has been something that has been recently growing thanks to the application of this NGS platform in the diagnostics, thanks also to the new guidelines regarding the genomic profiling of both these disorders, MDS and AML. Now, one of the key aspects is that recognizing the presence of germline predisposition is important in clinical practice for the management of the patient. We are at the EBMT, and of course, this is crucial for transplant because of potential adjustment of conditioning regimens, in particular in cases with DNA repair genes mutation or donor choice. If we identify a genomic mutation, which is a germline, we need to segregate the variant within the family in order to understand if we can use a related donor or not. And therefore, it's important to always have a multidisciplinary team involving also a human geneticist. In our institution, for instance, we have a combined clinic, and therefore assess the patient from both the hematologic and the human genetic constitutional point of view, in order to have also counseling for a family, which needs to be guided through the process of a diagnosis, which is somehow like a Damocles sword in the families of this patient, which previously didn't know that perhaps increased risk of leukemia was present or may be present in the family. Therefore, it's also important to always have psychological support for this patient. And of course, this raises the question of a lot of ethical concerns also for the unrelated donors that we use for allogenic transplantation, because the donors need to be consented. And yesterday was a very lively question, a very lively session on this, trying to understand what we can do internationally with our societies in order to have a unified framework to protect donors with regards especially to the presence of potential germline variants in these donors.
These insights highlight the importance of integrating genetic evaluation into routine transplant workflows, with implications for donor selection, conditioning strategies, and family counselling. Turning to disease-specific strategies, transplantation remains central in relapse or refractory classical Hodgkin lymphoma. Anna Sereda outlines updated guidance reinforcing autologous transplant as a standard of care in eligible patients, with allogeneic transplant reserved for more advanced or refractory cases.
So within the Harmonization and Guidelines Committee, the Lymphoma Working Party has undertaken the task to put some guidelines with respect to the use of autologous and allogeneic stem cell transplantation in patients with relapse or refractory classical Hodgkin lymphoma. So a group of experts, not only coming from Europe, but also experts coming from US, were gathered under the leadership of the chair of the Lymphoma Working Party and also myself. And we put forward several questions that were discussed online before the face-to-face meeting that happened at the end of September 2025 in Berlin. And we have already put a manuscript that has already been sent out for publication. So basically, which are the highlights of these guidelines with respect to auto and allogeneic stem cell transplantation. So first of all, autologous stem cell transplant is considered the standard of care for patients with primary refractory disease and for patients with relapsed disease. We try to achieve a metabolic complete remission with salvage chemotherapy strategies, and we try to include either brentuximab vedotin or checkpoint inhibitors in these salvage treatment strategies. The beam conditioning regimen is the most frequently used in patients that are candidates for an autologous stem cell transplantation. We can eventually consider radiotherapy either before or after autologous stem cell transplantation, after consultation with a radiation oncologist. And we consider basically consolidation or maintenance strategies with brentuximab vedotin following the data coming from the third trial, but also in specific cases, the possibility to use checkpoint inhibitors. With respect to allogeneic stem cell transplantation, we consider patient with relapsed refractory classical Hodgkin lymphoma being candidates for an allogeneic stem cell transplant if they have failed an autologous stem cell transplantation, and also brentuximab vedotin and checkpoint inhibitors. And we potentially discuss with the patient the possibility to consolidate a response, our prior response with checkpoint inhibitors, to be consolidated with an allogeneic stem cell transplantation. We normally use reduced intensity conditioning protocols in the allogeneic stem cell transplantation setting. Matched sibling donors, unrelated donors, and later on haploidentical donors are the kind of a strategy to be used in this specific setting. To allograft the patient with relapsed refractory classical Hodgkin lymphoma, peripheral blood stem cells is the most frequently used stem cell source for this patient, and we try to use cyclopost as GvHD prophylaxis platform strategy, basically in those patients that have received checkpoint inhibitors before allogeneic stem cell transplant. Finally, we don't have a standard of care for those patients that relapse after an allogeneic stem cell transplantation. And in this specific situation, we are eventually considering donor lymphocyte infusions plus minus brentuximab vedotin, the possibility to use checkpoint inhibitors, being cautious because of the enhanced risk of developing GvHD after the use of checkpoint inhibitors, and of course more conventional salvage strategies such as chemotherapy, radiation, and of course the first possibility would be to rely on the inclusion of the patient in a prospective clinical trial.
These recommendations reflect a structured and risk-adapted approach to transplant decision-making in Hodgkin lymphoma. In contrast, the role of transplantation in non-Hodgkin lymphoma is evolving in the context of cellular therapies. Anna Sereda discusses how CAR T-cell therapies have reduced the use of both autologous and allogenic transplantation, particularly in earlier lines of treatment.
So, both autologous and allogeneic stem cell transplantation have decreased in numbers in patients with non-Hodgkin lymphoma, basically in patients with B-cell non-Hodgkin lymphoma. And the major reason for that has been the integration of CAR T-cell therapies, not only in the third-line treatment strategy of more, and in this case, CAR Ts have been clearly competing with allogeneic stem cell transplantation, but also because of the advent of CAR Ts in second-line treatment for patients with early relapse or with primary refractory disease. Nevertheless, CAR T cells are not accessible around the world, and we have clear differences in terms of geographical access and, of course, in terms of reimbursement. And this is why we also have to look at potential strategies to optimize the results of both autologous and allogeneic stem cell transplantation, even in the CAR T-cell era. So one of the treatment strategies that we are trying to integrate and to combine with the stem cell transplantation, both with autologous and allogeneic stem cell transplant, are bispecific monoclonal antibodies that have been demonstrated to be very effective in patients with B-cell non-Hodgkin lymphoma. If we talk about autologous stem cell transplantation, we can use the combination of bispecific monoclonal antibodies with conventional salvage chemotherapy to improve the overall response rate and complete remission rate of patients that could be otherwise candidates for an autologous stem cell transplant. And we have some prospective clinical trials that are looking at this specific topic. And if we talk about allogeneic stem cell transplantation, there have been some retrospective analyses using bispecific monoclonal antibodies in heavily pretreated patients with B-cell lymphomas that are potential candidates for an allogeneic stem cell transplant. And information derived from these studies indicate that bispecific monoclonal antibodies being used before allogeneic stem cell transplant don't significantly modify the toxicity profile of the allogeneic stem cell transplantation itself, but can potentially increase the curative potential of allogeneic stem cell transplantation by improving the disease status before allogeneic stem cell transplantation and also the performance status of the patients potentially candidates for an allo transplant.
Finally, MRD is becoming increasingly important in guiding transplant decisions. Alexandros Viridonidis discusses the role of MRD across the transplant pathway, from informing the need for transplant to shaping post-transplant strategies.
Today in the business meeting and in the acute leukemia working party, we will discuss about the role of MRD during transplant. First, the role of MRD in the post-remission setting, and if this is an indication for transplant. We have now very good ALN guidelines how to handle this, but there are still open questions. For example, if some MRD negative patients with intermediate disease, if still they have to go to transplant or not, maybe we can omit transplant. Also, we know now a lot of how to handle MRD at transplant. We know it's prognostic. There are still open questions. We don't know if we have to treat it before, but we know that this has an actionable value. We have to do something after transplant. For example, targeted therapy like SLT3 inhibitors. If we can do pharmacological intervention like as a maintenance afterward, it's not clear. And if we should give DLI, it's also not clear. And so we have open questions on that. The most chaos and what we don't know, the most enigmatic, let's say, is how we handle MRD after transplant. What we don't know how to handle is how to measure and how to treat MRD after transplant. Because after transplant, the transplant per se is a dynamic drug. We have a GVL effect. It might be that it needs some time to clear the MRD. So first, we don't know the techniques, how to measure it. There are many confounders like in chimerism, like the DTA mutations. We don't know how to handle if there are host mutations or donor-derived mutations. And also we don't know when to measure. And if we found MRD positivity, how to treat it. So this is something that we have to work all together. There is also the Measure Consortium that is trying to answer these questions. And I'm sure that next year in EBMT, we'll have some answers in these questions.
Overall, the EBMT 2026 meeting highlights continued progress in transplantation, from advances in GvHD and evolving transplant strategies to increasing recognition of donor-related risks and the role of MRD. These developments are helping to shape more informed and personalised care. Thank you for listening. To explore more expert insights and interviews, visit bjhemoc.com. Follow us on X at bjhemoc to join in the conversation, and make sure to subscribe to our podcast on Apple, Spotify or Podbean. Until next time.